Yes, ma'am.
For people, and I'll try to repeat because that was something we got. For people in the world out there, the question or the comment was an individual who is here has used these services through a telehealth modality, and it was actually very, very helpful and useful. Is that accurate?
Yes, ma'am.
Thank you. If y'all have questions too, if you will stand and project, then I'll try to repeat, but I want to make sure people hear what they need to hear.
Heather Norton, DBHDS.
Colleen West with Aetna Better Health.
Amanda Becker with United Healthcare.
Nichole Martin, DMAS.
Lucy, or am I facilitating, or do you want to facilitate? Or
I was going to say, I can
just go for it.
I can go for it. So, at Aetna Better Health, you know, we deal with all of the requests that come in for our LTSS members, who are long-term support services members. And I directly supervise the group that reviews our AT and EM requests. A lot of times we've noted that COVID definitely put its own unique spin on life, you know, the option, the need for telehealth. But it also created a very unique response to AT and assistive technology, where our members had the request, had the need, but training and utilization of the equipment required kind of thinking outside of the box to make it happen. In fact, I recently had a conversation with a provider, and I'm sitting here saying, I want you to take our money. We have the funds. We are approving this. And many times it's that disconnect of the technology is there, but we can't do a one-to-one training to teach the technology. We need to do it by telehealth, and we're not sure how to convey that to get it paid for. So it's definitely taken a look at how we as a plan work with providers to make sure that first and foremost, the needs of the members are met. Because at the end of the day, it's not about us as a plan, it's about the members. And we, you know, look at the fact that this new opportunity for telehealth really does make for some expanded opportunities for training providers that are helping the members with this AT, that are helping the members better utilize. And as a gentleman here in our audience said, that ability to use telehealth has made understanding a little bit better. So we know that it's created some very unique opportunities. So really it's about working with providers, working with members, working together as a whole entity. Thinking outside of the box really is how we approach things and how we ask the AT providers even to start looking at things. Don't think about, is this service covered? Because at the end of the day, we look at the services as, are they benefiting the member? And they do have to meet certain criteria, but we know that we have flexibility within that criteria because DMAS says, but is it in the interest of the member? Does it benefit the member? Does it benefit the ability to use the AT that the member has the rights to? So there are a lot of things that people go, but it's not going to be covered. Don't walk into it with that frame of mind. And I think that's the number one stumbling block we see from providers, and we see from even members and families going, but we don't think it's going to be covered.
You don't ask.
And that's exactly right. And that's the biggest thing is we want you to ask. We want to see these requests come in. Like I said to a provider, I want you to take our money. Would you send the request in? So a lot of times it's getting the providers to say yes. and to doing, having that outreach and being able to do that outreach with these providers, it's a constant. And, we want to hear from providers. We outreach providers. We don't want families to feel like this is inaccessible technology, because it very much is. And we want you to be able to access it, have the resources to be able to learn how to use it, even if it's a telecourse. And we want to see that succeed. And we, at Aetna, our part is to help that be successful, help members be successful.
I'm wondering if we can just go back a little bit. Yes. Go ahead.
No, but what were you going to say? Because I was actually going to ask questions. So I guess I want to hear from you all what is and is not working, right? I mean, because really, in order for us, I think this, so forgive me because I'm still reeling from lunch, because as most of you know, that stuff just is very important, I think, to all of us. And so in my mind right now, what I want to know is what is and isn't working, because we have to take the opportunities that are presented to us. I don't get in front of 50 people every single day. And so I want to know what is and is not working so that we can start to move in the right direction. And, and that's part of the reason why you're all here, right? We didn't come scripted with a presentation, because really it's about you and what we can do differently and better, and what we need to know. Because there's also a couple of you in the room who also know that I think that there is a right time for telehealth, and then I think that there is not. And I'm going to own my personal bias on that, and that's the other reason why I want to hear from you all. So, we're getting ready to say something.
Not telehealth, though. So okay. I'm going to wait, I guess. It's ATM.
Okay. Well, go ahead, and then I'm yes, please, and then
okay.
I'm going to do Jenny, and then I'm going to go back to Stephen, and then I'm going to come over to you, because I just want you to. I've seen everybody's hands. I've got you in order.
Okay. I think there's a big difference between what is approved from DMAS when somebody has, let's say, a CCC plus waiver versus when they have a DD waiver and it goes through DBH. It's incredibly different. Actually, DMAS is much more flexible, I would tell you, than DBH draws this line in sand, and their motto is really, let's deny everything.
Well, and you were also questioning in the last session about when you are asking for AT or EM, not you specifically, but in general, you have heard that the example she used was, we want to improve accessibility for our son in the house. We want to have an elevator put in. We know that it's $20,000. All we're asking for Medicaid is the 5, but they can't get it because they're going, why don't you just put a ramp?
So even though a ramp might cost $6,000, it might cover your whole yard.
Right.
That's the cheaper thing. DBH says, and the appeals through Medicaid says that's the cheaper way to go, even though both accomplish the same thing, the same $5,000 is paid, but the ramp is going to cover the whole yard where the elevator is not.
So is there some consistency or changes that we can make?
Absolutely. And this is exactly why I asked the question I asked, because this is the feedback we all need, because it's either retraining, re-education, consistency, all of those things. Okay, Jenny.
Yeah. So first, I got the biggest waiver in the whole state of Virginia. I see people with SSBA, and they have no waivers because I have a friend of mine who helps me, and he's been talking and cutting every single day. It's Chip. Every day that Chip has been talking about the whole thing that I went through.
You mean that
Chip
Chip
is
back
an
there?
amazing person I've never seen.
He is an amazing person.
This waiver, I never have. So we need to say thank you, Chip.
You put her up to it.
Thank you, Chip. Thank you, Chip. We think you're amazing too.
So are you saying SSBA supports people that have a waiver and that do not have one?
SSBA. Not even the company, except Chip is the only partner.
Yes.
In me.
He's pretty awesome.
He's great.
And Jonathan.
Okay. Thank you. Stephen?
First of all, DMAS requires too much documentation. And secondly, and it's a violation of anything to not live in the least restrictive environment. I do not understand. Don't understand why DMAS would rather take the easy way out and pay a nursing home. It's more cost effective to live in a community.
Agreed. Yeah, it is. And that's why we have waiver programs that are pretty robust, that have 152 services in each waiver, and that people choose to live in the community instead of a nursing facility. That is why the General Assembly this session approved rate increases, recognizing across the board that these services, even though some of them are still low, needed increases in order to retain providers and attract providers in a world that we have major workforce issues across the board. It's not just in nursing or DSP, it is across the board. And so they recognize that community-based services are in general less restrictive and more cost-effective, but it really is about being part of the community. So otherwise our General Assembly every year would not approve slots so that people have access to those services or the increases. Thank you, Steve.
Just 1 second, the gentleman in the blue shirt.
Yes, hi. My name is Brian Jones. I'm a senior program director for Healthcare. And we had a site here in Hampton. Well, we have a site in Hampton. We also have a site in Nichole. And part of the issue that we had as a company is that our site, the sponsor residential DSPs that we had in Lynchburg had a really difficult time working with the technology because they have difficulties with the area that they're in.
Right.
They have a big storm, their technology goes down for a number of days, or sometimes the technology doesn't work because they don't live in an area where they have the antennas and things like that. So that's what some of the issues are that some providers are having, because we're talking about providers that are in rural areas. They really have a different type of issue relying on technology and things like that, and those who don't. Even when it comes down to trying to set up a supervisors are having, why they aren't necessarily ready to jump on board with technology, because they don't really have a way of sustaining this technology right now. And that's something that I feel like we need to work on.
Yeah, that's good.
To kind of expand on that, that's one of the things that I know that we specifically look at for when we're looking at our assistive technology requests. Sometimes it becomes a barrier to being able to approve the appropriate technology, because one of the things that our expectation of the provider that's providing said AT for you to access is that it has to have ease of access. It has to be reliable and dependable. There has to be a backup method that can be employed in the event of a service outage. We actually encourage and implore our case managers to work with our members who have difficulty when accessing and utilizing telehealth for visits. Sometimes we, as the plans, have to speak up to prevent those providers from discharging because of an access issue. And we do. We actively get involved in those cases. And I deeply implore you, situations like that, you need to outreach the case managers with, if the MCO or the EHBS or the CSBs, because they should be an active component in helping and assisting through those difficulties.
I'm trying to learn some of this too, so Amanda, I wanted to ask you, either one of you. I know one of the optional benefits under certain plans is that sometimes the managed care entities give cell phones because they want people to be able to connect with their support coordinators. Do those cell phones, even though, please understand, I know rural, even with a cell phone, it's catch-all. Do they have hotspots or the ability that the person could engage in telehealth through the cell phones?
Show video.
They are smartphones. Yeah, they are smartphones. And there are some limitations, so it's really on a case-by-case basis. So the care coordinator kind of goes out and does that assessment of where does that person live, what is the broadband access, what are some other resources that we might be able to utilize. We've been working with like independent pharmacies that can sometimes be a place where people can get broadband, right, that are in smaller, counties. And really kind of figure out a way that they can leverage using that technology either on the cell phone or finding them tablets or whatever they need, so they can really meet that technology.
Sorry for the rabbit hole. I just all of a sudden realized, wait a minute, I do it on my phone sometimes. I wonder.
That's an excellent question.
If that, because they get them for free, essentially. I think there might be a capped amount of data wattage or usage or whatever it is, that might be also another option that individuals that are here, if you haven't thought, and you're in CCC Plus and with one of the managed care entities, you might be able to leverage some of the resources that they already provide you. I know a lot of folks, not sure where it came from, there's a substantial amount of funding given to expand broadband services. I tell you, COVID wasn't all that great, but there were some really good things that came out of it. And so I know that that's starting to be deployed. I have Middlesex County. That's one of the ones that was, I think, upped and got some stuff. And then it's about the third-party providers that can do it. So I do know that some of the more rural counties did get some funding towards broadband. I'm sure that y'all could all still benefit from more, right? And I encourage, where you think that that's a need to articulate that to the legislators too.
And one of the other things to kind of expand on that too is with the expansion of broadband access, there's a lot that's been done within the school systems where they have set hotspots up throughout the community. One thing that we're finding, especially in rural communities such as where I'm from, in the Charlotte courthouse area, is that those broadband access points are available to individuals who need to go through the health department or the CSB, not just to the school children. It was set up primarily for the school kids. However, they've realized that there is a broader service group that needs access and accessibility. So in the rural communities, that's definitely an outreach resource to go to is through the DSS and say, we need this broadband access. Can you give us the hotspot link? Or, you know, where do I go to pick up the hotspot so I can do my telehealth visit? Whether it be go to the courthouse and, you know, access their hotspot, or, you know, go to the CSD, you can access there, or there's a hotspot right around the corner from you, it's off the water tower. There are a lot of access points available even in the rural communities. And it's really about knowing where to go to access and how to get that access. So,
and that's not always perfect, depending on the types of services, right? If you're doing a group day program or a community engagement at your home, to go to the school and sit in a car might not work, but at least that could help with a dentist appointment or a pharmacy appointment or something like that.
Deanna?
Yeah, interestingly enough, back in 2012, when I was a case manager, I had more success getting AT stuff through DMAS, through justification and those kind of things, than what I see is accessible to people now.
Okay.
I see a lot more denials come through now. You know, I think if you have a good support coordinator and you're on the EHBS side of things, you can likely have a good proposal put forward, but the likelihood of it getting approved is kind of iffy. But my experience with the CCC Plus side of things is it is such a challenge to get anything approved. I mean, all I wanted for my daughter was a walker that I could use in the home. She still crawls around our home. She's 15, but she still crawls at points. And I don't want a dirty walker that I use in the community and take it to public bathrooms for her to be walking around my house in. So all I wanted was, you know, that. And it took like trying to explain why it was so important. Well, you know, maybe you guys walk around your house with shoes on, and that's fine and dandy, but we don't in our house. We walk in, they come off, you know. So I just think that it's interesting that we've gone 10 years and it's harder to get stuff than it was 10 years ago, when you would think we didn't have enough money in the pot, it didn't seem. And now there's money and people understand the needs people have, and it's about the members, but it's not. So I think that there's some disconnect there. But on my side of things, unlike hers, I actually had more success in GBH side of things than I have on the other.
Chip?
Thank you. Thank you.
On telehealth, first the way you phrased it in the beginning, it took me a second to get my mind around, like, it was like in person's better than Zoom, right?
Well, I didn't say it was better. I just said at some point people need to be seen.
Yeah. And I think, well, like maybe personally, it's different to see somebody here. It's not to the provider conference. It's perfect. But another way to look at it, maybe if you're advocacy to get more approvals from whoever your efforts are to say no, it's in person or it's telehealth. We have zero. Telehealth is better than zero.
Oh yeah.
Right? Therapeutic consult. He just showed us in our Let's case at the DOJ. If we allow therapeutic consult, at least part of it, to go through telehealth, at least we're getting people something instead of the pathetic numbers we have today. Yeah. So that would be one thing. Go from nothing, something better than nothing, and your advocacy. One of the things I heard recently here was that psychiatrists, like one of my staff were there saying she has a guy in crisis needs a med change, something like that. The psychiatrist was changed, like at 8 weeks we see him. So psychiatry is another one. We had like go to an office and wait in line to get an appointment. Meanwhile, Amazon, I think we bought One Health or some big company. It's going to be where you talk to your Alexa, which is HIPAA compliant on some of the skills. You say, Alexa, I need meds, and the doc pops up, and all of a sudden 2 hours later, meds are on your doorstep to Amazon. Like somehow, if Virginia can get into that and bypass the system that we currently have.
You actually brought up a good, and I'm sorry to the people that are online, I just can't repeat all the dialogue. You brought up a good point. So we kind of talked a little bit more about, and I started it with the DD waiver because that was one of the things that Lucy was talking about in some of the legislative stuff in the work group. But there is still Medicaid. There's this whole world of Medicaid, which Amanda and Collen represent, that pays for a lot of other stuff. I do know at levels way above me, they are looking at telehealth or telemedicine appointments at that, and what is the flexibility, what do they need to do with the feds. So outside of our services, to your point, they are looking at more other flexibilities or changes to our system that reflect the usage of that.
And we're advocating
Yeah.
as well.
And check with your MCOs, because some of the MCOs do have access to telehealth. Virginia is very particular in the fact that you have to be licensed in Virginia. We don't allow like a psychiatrist from California to do services here. That's kind of a stumbling block that we're really advocating to say we need to open up the borders of Virginia. But a lot of the managed care organizations, the United, I can't speak for anything else, but have actually telehealth, either companies that they own. I know Optum, that I'm part of, owns telehealth companies. I know that they have access to those. So working through those care coordinators through Medicaid would be a great way to really get that access.
I guess the other thing with the cost of the equipment itself, like the Amazon, it's not Alexa. Alexa's the voice thing. The Amazon Show is the little box with the video screen. Talk to your grandma. If we had a skill with the typical climate, that way basically every home could have $50 little box with you on it, and we could actually do real, not just prescribing meds, but just checking in on people and talking about how are you doing.
Well, and that's where the equipment, if someone's DD waiver could, or CCC plus, could potentially be paid for, right? So that there's some avenues to do that so that they can access the service. Right. Maybe not everybody in Medicaid, I don't know.
Karen, Deanna, and you, and I'm sorry, your name?
Jamie.
Jamie, and then we'll get Erica, thank you. Karen?
Okay, so this is where I get confused because I'm learning on things I'm learning for moments too, especially working on a workgroup. There currently is a $5,000 limit in the G plan.
I think it's CCC.
Yeah, it's the
CCC plus waiver and
TD have a $5,000 cap per calendar year.
10,000.
And then Medicaid, so it would be CCC plus Medicaid.
But,
Okay. Do they have a dollar limit on AT and DM?
so you're
DME?
talking durable medical equipment. So there is no AT outside of CCC plus waiver, correct? EPSTD, except it's EPST2. So straight Medicaid, just state plan Medicaid, go through the plans. There is no assistive technology service. It is durable medical equipment that everybody and his brother who has Medicaid has potential access to. Then there are 3 subsets of Medicaid recipients that may have additional services or be part of additional programs that could have access to environmental mods, assistive technology, and some other. That would be DD waiver recipient, CCC plus waiver recipient, and EPSDT. Correct.
And EPSDT is for anybody under the age of 21 who has Medicaid. So it's not a waiver, it's not anything that you special that they need to apply for. It's just part of their Medicaid benefit.
Right.
And
So
they don't have to have waiver services to have it.
Call Jonathan, he knows best.
Okay, so Karen, I guess my follow-up question is, under EPSDT, there's no dollar limit.
Not for 18.
Correct.
Okay.
But that was for 21 under, is that what you said?
Yeah.
Okay.
And one
Under
example,
21. Under 21, sorry.
one example just for assistive technology, my daughter is getting an AAC device, but through DME, not through assistive technology, so it's coming faster and not having a limit.
Right, that's what I was saying in the previous session. There is a lot of AT that it's considered under durable medical equipment from straight Medicaid.
And it doesn't matter, it's not that 5,000 limit, it's separate.
Correct. It's
Yeah.
And that's one of the things that we see is that we always try to make sure that when requests come into us, that they're going through the least restrictive method to obtain the equipment necessary, because we don't want to utilize a limited cap benefit if it can go under something that's not limited, because that's to the benefit of the best
So
interest of.
when you say we need to check to make sure it can be funded under Medicaid. You're talking about DME.
Yes, ma'am.
Okay, so in this wonderful stuff that Angie sends out from DMAS, she sent us some stuff, and under the DME stuff is where I get lost. It's sort of like the old-fashioned way we used to write regs. We list all of this stuff, right? So people interpret that, and if it ain't on the list,
right,
we're not going to fund it. So,
and that's why, to the question before, we don't want to put a list because technology is ever changing. We don't want to box ourselves in.
So maybe we should look at or explore how we can expand the DME, because things have changed so much, right?
Yeah,
it's
definition.
It's tied to the feds.
It's tied
Tied to the feds, and we did just expand that right around COVID. Pretty like augmentative communication devices and things that hadn't been covered before are now covered. Yeah.
Part B, in Part B.
I think so. I think you got it. Yeah.
So is looking at DME first or Medicaid first before you look at waiver?
That's a requirement. That's a requirement.
Okay. Is it consistent and is it enforced consistently? From the provider field, we don't see it being consistent or consistently enforced between all the MCOs and stuff.
I would agree to that statement. From feedback from members that have bounced, we hear that.
Are you saying that you're seeing people get things through AT that should be DME?
Yeah. Okay. You know, I think the tough part is we hear all kinds of stories, but I'm just thinking, how can we help resolve some of these things that may not necessarily need a reg change?
Mm-hmm. It feels like training.
Yeah, I was going to say a lot of it is provider training. You know, within the MCOs.
So I know in my case for the walker, the reason like we had to go through AT for our walker with the CCC Plus was because we already got a walker and it was within the time limit of like you can only get a walker every what, 3 years? Is that right?
Yeah.
But not under EPFD.
Oh, well, that's
EPFD
we're underway
says
right now.
anything that's medically necessary, correct, or ameliorated.
Yes.
So we want to make sure we get to other people.
Yeah.
Oh no, I thought I was after Karen anyway.
You are, but there, I think somebody wants to chime in.
Yeah,
so
no,
go ahead.
I'm sorry, no, just there's someone on the line who asked a question.
Okay, thank you.
The only thing I was going to ask with your work group that you guys are doing,
Yes.
what is being talked about with environmental mods to access telehealth? Like what are some of the things you guys, is there anything in particular you all are talking about or things that are coming up in that work group that you're saying, well, people are saying they need these types of modifications environmentally to be able to access telehealth services? Because I'm kind of looking at the descriptions. I was just kind of curious if there was discussion around like what are the things that you're hearing that people are needing to make things like that more accessible.
When you say environmental mods to access telehealth,
I was
can you
just
give me an
curious.
example?
Well, I don't know. It just says in here that, you know, the change opened up assistive technology, environmental mods, and West-based or funded services that may need to access virtual support. So it made it sound like those three things are being talked about, and how do we need to make them usable for people to access virtual support. So I was just kind of curious what the environmental mods that were being talked about, like, or if that was just not worded in that way.
I think it's the way that it was worded.
Okay.
We are talking about environmental modifications and access to environmental modifications, but I don't think we're talking about
Related specifically to
Yeah, the
telehealth.
EHBS maybe could be tied, but
I was just curious too. I know there's been talk at different points about combining the amounts instead of making it 5,000 for this and 5,000 for that, because maybe this year I don't need environmental modifications for my daughter, but maybe we need an assistive technology, something that's going to be over 5,000. Or, you know, what happens to those funds at the end of the year? Do they go in the general fund? What kind of comes of that money if it doesn't get used? And do we have talks at the state level of really saying, this doesn't make sense. If I need a wheelchair lift, a stair lift in my home, it's going to cost me $20,000. Can I just use 10,000 of the funds and not assistive technology that year? Like, I really think that that's important.
There was legislation put forth last year that did not pass. So I do not know if Karen's group, the ARC, is trying to push that forward again. I believe that they've spoken about it in the work group to see if they could try it again. At this point, we do not have the authority to do that. Correct? Yeah.
We don't know whether we're doing legislation or budget amendment.
Right. Right. Okay.
Jamie?
So, and I probably know the new case management. Have a client, not the same one, that I'm trying to help him get the DD waiver. He has Medicaid. He had a stroke at 18. Now I realize that they probably don't see that a lot with DD waiver for a stroke that young. But I worked with brain injury. I gave them 400 pages of documentation from the UVA about what the stroke did as far as hemiparesis and his vision problems, all kinds of things. All they did was say, we're not going to read all this, and a stroke is not a brain injury. And that's not true, because it happens in your brain and causes dead brain tissue, and that's all in his documentation. They want him to have a psyche eval, but I can't get him in anywhere forever. He has Aetna Better Health, and that's not really taken as much down this way. So I want to know, does he meet 18 things also? He had to quit school.
Did you say he's not a DD waiver recipient? Or
Not yet.
Not
yet.
Trying to get him.
yes?
Trying to get him
Okay,
on.
just making
So
sure.
wait, what you need to do is send your documentation to me.
That works.
And I'll review it with our team, and then we'll reach out to to who we need to have a discussion about what a brain injury is, what qualifies as a developmental disability, and do some re-education, because that's what we do in our office.
That's a big deal to me. So I can send it to our brain injury rep at DARS, and she just went along with them and just say, well, whatever they said.
That's not how that works. So when you bump into many of you in this room already know this, but when you bump into those issues and barriers, then you just heather.norton@dbhs.virginia.gov, and you send that on to me, and I will review it, and I'll
Send it to me.
and between the two of us, we work to resolve those issues. So that's what you need to do with that.
Okay.
Do you want me to read the question on
Transitional care
that?
coordination.
Just, I have to go to Eric.
Just, okay.
Did I remember correctly?
Yeah, I went for brain injury services.
We're just going to do TV and wait.
So I have to do with environmental modifications. We're just starting the process of getting to use the funds, but what I am finding challenging is that there are not many contractors or whatever who will actually do it, because it takes forever to get paid, is what I'm hearing, that the paperwork is ridiculous, the amount of, how much is each screw, basically, that the amount of ridiculousness that's required, and so nobody wants to do it. So even though we have funds available, and like you guys are saying, take our money, well, they can't, because of the required paperwork or whatever that is needed. And so it's so close to impossible to get environmental modifications done because of the requirements.
Heard.
Something we'll need to break down. You had your hand up again.
No, yeah, no, I just have a specific case of someone who was denied and has his own place, or he uses small assistive technology education or just he's half blind and have other health issues, but he was denied Medicaid waiver. nursing home, but she can do almost everything, just need some support in his own home to be able to navigate through.
If a screening, an LTSS screening packet was completed and the screener denied it, you definitely, that can be appealed through, if it was done by a DSS, by the regional, to the regional DSS.
So those are trying to help him. It's not like they know the system, right? They don't know exactly what to do next. And you're not given those options like, okay, you were denied, but you have this option where you can appeal the things and days. So when they just get that letter denied, then that's it, right? Unless they know the system what they need to do next.
And so while they can appeal, if they don't remember that, right? Because that's happened to a couple families I've worked with. We just start the process again, and then when they get denied again, then we appeal it, right? Because you can get re-screened. And then if you get denied, then you initiate the appeal process, which is why I am happy, honestly, send people to me because we've talked families through that when they've gotten denied and they didn't appeal within the time frame. Then you just reapply and then the time frame starts all over again and now you appeal. So please, by all means, feel free to reach out because, you know, sometimes it's about, like you said, people don't know what they don't know. And sometimes we don't know who to contact. They're excited. I'm re-energized and refocused. And so reach out. Chip.
One of the common themes I think has occurred in not just these sessions, but in there, this getting things approved process is very good.
Yes.
In the old days, it was like you could apply, you could have stainless steel refrigerators and everything. It was on the provider. If you get busted, you know, because you got too much or whatever, you pay it back, right? We went from that way extreme over to you can't get anything to go through unless it's absolutely perfect. But then there's the problem we don't talk about a lot, which in there they were talking about the 25% reduction in back office costs. It makes no sense. The increase rate 20%, but making it 21% back office, right? It doesn't make any sense. Going with the DSPs to the raises. But every time something gets pended or denied, calculate the amount of hours, both the CSP and the provider level, and cash flow delay. I mean, it's a huge expense. And I imagine this cartoon in pre-op where like you hit the pen button, you get a donut, you get shock administered, you get approved. You know, and like you got a Pez dispenser on that side. And it's like we gotta switch it where it's like you better pen it for a damn good reason. Because put some of it back on the provider. You ask for something, you're paying it back. Maybe not with family, right? I get that because they're not going to afford to pay back, but a provider that wants assistive tech for an in-home, no, if they didn't need it, just come back and audit me from time to time, and if I did it wrong, you did it. So I don't know. We just got to speed up that process.
You know, from a provider, from a plan standpoint, I see very few requests for AT even come through the door.
Right.
I think it's because of the fear of getting.
Yeah.
Well, and also finding the provider to do
That's
that.
a big issue.
When Moms in Motion stopped doing the Ability Unlimited,
Yes.
now where do you find an AT provider? If you're fee for service, where do you find an AT provider? Yes, I know you gave us that link, but that's not accessible. And so finding the providers for AT or EM, if you can't find them, then you can't submit to you guys.
And a lot of people go, oh, but they have to be in network. They have to be a car provider. There are so few AT providers. We have to look at every request. Doesn't matter if they're car or not.
But we got to get more good requests.
Hear what she says. Hear what she said.
It doesn't matter. Ask. Exactly. We can always get them through the credentialing process.
Or do a single case agreement.
Or do a single case, exactly.
So if there may be waiver providers, it can be the CSP who acts as a provider if there is a one,
Right. Yeah.
per se. So,
Right.
well, and
you know, as far as, and I can't speak for the DD side, but
It's a no at the moment on the DD side.
Right, but push for it.
But you might want to advocate for that as well. I would say.
single case.
If they're willing.
If they're willing.
If they're willing.
I have one more thing that's not working, not necessarily just AT. I have a family that I've talked to. They have CCC plus waiver with Anthem Housekeepers. They have their primary health insurance. She's now in the process of trying to find a new nursing company to come in because the one they were using, they're trying to find a new equipment company. He needs ostomy bags, he needs feeding tube supplies. And she's finding this one will take the primary for the ostomy supplies, but they don't take the secondary, so she can't use that one. So then she's finding this one will take the secondary for ostomy supplies, but not the primary, and because we can't override anymore, where it used to be if, before MCOs, if my daughter was getting a prescription and my primary insurance would not pay for it, then Medicaid would pay for it. Now, if your primary does not pay for it, Medicaid won't pay for it either. So that's where she's run into 5.
So this is a medical issue. We were just kind of talking about ATE, EHS.
Well, this is all, yeah.
So
in general, it's not working.
Right. No, I understand that. I can pass that on to Jason Rachel about who's integrated care at DMAS. Just about there's some inconsistencies there. It may be that you need to reach out to me directly what your issue is. I can then forward it to that team and then they can look across the system.
And she even called both her primary insurance and her
Understood.
Medicaid to ask for a ostomy provider, and they gave her hearing aid providers.
Understood.
She's like, he needs a bag that captures the poop that comes out of him, not hearing aids. So she's been very.
I know we're after time, Lucy.
Yeah, you guys have been very generous with your time. You started late, it wasn't your fault or anything. So I hope people got some questions answered. I hope maybe you have more questions in your head, but now it's really easy because you call Heather Norton.
I was going to say, send them to Lucy and Lucy can send them to us.
Or do not hold back on your questions. It's a very overwhelming complex system that people have to work through. And thank you very much for the time, your listening, knowing what's expensive, it's great. So let's give them a hand.
You guys have to start with
Hold on one second.